This program is brought to you by Emory University.
Hi, good morning, everyone. It's my pleasure to welcome back Dr. Dan Zarescu, who we introduced a couple of weeks ago. And so this is part 2 of his series. And today he's going to talk to us about a tale of sugar, fat, and salt. So we look forward to this talk. Dr. Zarescu.
Good morning. Thank you, Pooja. So this particular part will be mostly about actually clinical trials in nutrition. And the purpose is actually to target the clinical trials that actually have shown to improve insulin resistance, which is in charge of 67% of residual risk in our cardiovascular outcome trials, despite high intensity statin therapy. So this is about food. And the question is, how can we eat healthier, and what evidence we have about that? But when it comes to food, there is actually helping patients to adopt a healthy dietary pattern has gotten very complicated. And the reason is we all have biases. Turns out not only us, but also the scientists have biases when actually design the clinical trials. And this is called actually in psychology, confirmation bias. Yeah, we kind of look for things they already know and confirms what we already know. For example, what causes cardiovascular disease, there's been a fight for over the last 50 years. Is it fats? Is it carbs? I'm one of those who have the biases. It's about both, particularly when refined as ultra-processed food. But when it comes to evidence about bias in science, here is an example of 60 trials who have been reviewed in this meta-analysis published in Annals of Internal Medicine. And they try to answer the question, do sugar-sweetened beverages cause obesity and diabetes? And it turns out if the food company was sponsoring the principal investigator, they found no association. In contrast, if the principal investigator was not sponsored by the food industry, they found 34 associations. So yes, we have tremendous bias, and I can actually design any clinical trial. They'll prove whatever I want, depending how I design it. And that is the major problem trying to review these clinical trials. This started over 50 years ago with a major dilemma between Dr. John Yatkin, who was actually a nutritional biochemist at Queen's College in London, who actually said, well, it's the high sugar intake that causes cardiovascular disease by looking at the incidence of cardiovascular disease in worldwide. Meanwhile, Dr. Ansel Keys in the 70s, who was actually named the cholesterol man, said, well, it's the saturated fat that's causing that based on the 7 country studies that he published. And at the end of the day, Dr. Ansel Keys was the one who actually won, at least in the academic conflict. However, Dr. John Yatkin published a very popular book, How Sugar is Killing Us and What We Can Do to Stop It. And it's actually a good read. It was recently republished by Dr. Robert Lustig. It's basically he summarized and predicted over the next 50 years what happened with epidemic of cardiovascular disease and chronic metabolic illnesses in our country. The irony of it is actually that as Dr. Ansel Keys moved to Payapi and ate actually Mediterranean diet for the last 25 years of life. And he's the first one to actually introduce us the solution to unhealthy nutrition, actually the concept of Mediterranean diet as a way to help us. And paradoxically, this actually is a high-fat diet. And now we know that actually there's absolutely no evidence that reduction in saturated fat intake actually improves cardiovascular disease outcome. This is a meta-analysis that was published in most recent meta-analysis of Cochrane Review in 2020. As a matter of fact, last year at the American Heart Association meeting, Dr. Frank Wu, who is the current chair of professor of nutrition at Harvard, showed that actually how low-carb diets actually can help us improve cardiovascular disease. So really, this hypothesis that fats causing cardiovascular disease, which has been actually the backbone of our FDA guidelines and food pyramids since 1977, were based on the fact that cholesterol and animal-derived fat are bad. We need to replace that, and we actually did that. We replaced whole dairy with skim milk containing sugar. We replaced the saturated fat from animal with vegetable and processed oils that have trans fats and inflammatory omega-6 from vegetable oils, particularly when you cook them at high temperature. We stopped traditional slow cooking, and now at lower temperature, we cook fast at high temperature, which actually tends to oxidize our fats and our sugars. And I'm going to show you data for that. And we started juicing, which means we destroyed the fiber from our fruits and vegetables. I'm going to hopefully convince you over the next 45 minutes or so that the main reason for cardiovascular disease is actually increasing our both refined carbs and refined fats from ultra-processed food that led to this epidemic of morbid obesity, insulin resistance, and cardiovascular disease. So we're going to start first with the strongest evidence we have, which is randomized review, the randomized clinical trials of low-carb diets, particularly Mediterranean diet versus a very low-carb diet such as keto. And it's important, although we're all familiar with Mediterranean diet, keto diet actually has become mainstream, and lots of our patients will ask about us. Also, we are starting to focus, and we really want to know what's the safety from cardiovascular perspective in long term. And we have two clinical trials from Mediterranean diet, and unfortunately, they are the only long-term randomized prospective studies. One is a primary prevention study, the PREDIMED study, which randomized about 7,000 patients to the back then low-fat diet, American Heart Association style, versus Mediterranean diet supplemented either with nuts or with extra virgin oil. And initially was published in 2013, was retracted because about 20% of the patients had issues with randomization. Eventually was republished in 2018. And having said that, there was about 28% reduction in cardiovascular MACE by 5 years. But more interesting study actually is the secondary prevention trial. This was the Lions Diet Heart study that was published in 1994. It was done in France. Patients who already had myocardial infarction, they were randomized to Mediterranean diet versus low-fat diet. And there was actually about 70% risk reduction in cardiovascular outcomes at 5 years. This was a smaller study, 600 patients. And this was before the era of high-intensity statin, which would have been fascinating and know a study like that, what would be the outcomes. Nevertheless, if you look at this PREDIMED study, what was fascinating is that these are patient population that are very relevant to the patients we see today. 50% of them had type 2 diabetes, 70% had morbid obesity with a BMI over 30. And to me, if I were to improve cardiovascular outcomes, any diet that works, it should work by also improving fatty liver insulin resistance. And in subsequent analysis, actually, they showed that it did prevent Mediterranean diet, prevented in these patients new onset diabetes by reduce it by 50%. So that's a key point here to take home. What about keto diet? And in theory, this is how keto diet works. Insulin resistance is caused by elevated insulin. If you carbs are the ones that stimulated the most, fats stimulate the least. If you actually lower carb enough in the diet, hopefully we can change this pattern from insulin resistance to more of the peak and trough level back to normal level. And it turns out that you need to reduce actually your carbs, total daily carbs, to about less than 30 grams a day, ideally 20, which is less than 10% of an average American currently eating about 300 carbs a day, carbs a day. And if you do that indeed, and you start to measure ketone bodies, you start to have nutritional ketosis. This is not to be confused with diabetic ketoacidosis. So this is actually healthy use of our fats. So what kind of evidence we have that keto diet, it's either safe or it's sustainable for our patients with cardiovascular disease? So the first study, there was a larger study, it was randomized and prospective. It was published in New England Journal, looked mostly as a weight loss as an outcome here. It was done in Israel. And if you notice, they randomized actually patients to either low-fat diet, which is AHA style kind of diet, Mediterranean diet, or ketogenic diet. And really the first 2 months, they were actually strict. They made sure that the patient were under 20 grams of carbs a day. And with it, you can see that when the first 2 months, patients lost the most weight in the keto diet. However, after 2 months, they allowed patients to gradually liberalize their intake. By the way, in the first 2 months, there was also 1,500 calories, restriction. They also insisted no refined carbs. In other words, they avoided. These patients actually ate healthy food, and by the end of the 2 years, was surprising. They had actually 84% adherence to these different kinds of diets, and indeed appeared the Mediterranean diet and keto diet appeared to be superior to low-fat diet in achieving weight loss by about 5 kilos. When they look at the lipid profile, the ketogenic diet appeared to be the best to raise the HDL. There wasn't really major, maybe there was a tendency for the LDL to go down, and there was a clear improvement in the ratio of total cholesterol to HDL and triglycerides on the keto diet. And the main concern with the keto diet is the fact that obviously when you go down on carbs, you're going to go up on the fats. And indeed, in small randomized studies, the LDL cholesterol tends to go up by 10 to 15% in this patients who follow this kind of diets, and that could be potentially deleterious for somebody with cardiovascular disease. And however, if you look at the subparticle analysis of this type of LDL, most of the LDL is actually the buoyant part, which is actually kind of neutral from cardiovascular disease perspective. And that's the one also that's affected mainly by the statins. If you actually look at the small dense LDL and even the lipoprotein A, triglycerides to HDL ratios, insulin drops by 50%. So if you were to look at particle profile, a subparticle profile, actually it doesn't seem to really correlates with increased risk. And this is another study that looked more careful to actually hormone analysis. And the same way, I found a dramatic actually improvement in insulin level, 50%, but also leptin resistance, and what was fascinating, the measure actually the saturated fatty acid level in the bloodstream. And turns out when you cut your carbs, you actually burn more of your fatty acids despite of going up on it. So that's something to know. But probably the most and the best study we have so far is the interventional KetoMed randomized crossover study, which was published last year, was really designed by Dr. Christopher Gardner at Stanford. And I love how this was done. For the first 12 weeks, patients were randomized to either keto diet or Mediterranean diet. And the next 2 weeks, they were crossover. And then the last 2 weeks, they are kind of left on their own without any coaching to see if they're able to actually stay on that type of diet, because you wanted to test what is sustainable and long-term and what's the ability to continue that. And another point that I like to make is that Dr. Gardner insisted that this should not be ultra-processed food, that they really strongly remove the refined carbs and sugars from the diet. So this would be a healthy Mediterranean diet versus a healthy non-processed keto diet. And the main outcome actually was hemoglobin 1C. And basically, these are pre-diabetes and diabetes. Does it really make a difference? And the truth is, both diets actually achieved improving the metabolic profile for the patients at 48 weeks. Maybe there was a tendency for keto diet to be a little more, to show a little more improvement on hemoglobin 1C, insulin level, but also cholesterol profile, here fatty liver as measured by ALT level. The weights were kind of similar. They both lost in the 6 to 7 kilograms range. And the weight was actually maintained at the end of the 36-week period. However, after a while, the patients were encouraged to gradually increase their carb diet on the keto stuff, on the keto side. What I like about this, actually, look at the retention rate and how compliant how were patients able to actually comply and continue with this type of diets. And in the first 24 weeks, as I said, they actually had their food delivered at home. Even then, it's surprising some of the patients were not very compliant and eating that. But really, when they were left on their own for the last 12 weeks, notice that only actually 10% on the keto diet had a compliance score more than 5 out of 10, and only 30% on the Mediterranean diet. And if you were to summarize what were the advantages and disadvantages for this, so the Med Plus diet theoretically is better because you have more fiber and better compliance. Unfortunately, with time, you tend to drift towards higher carb and starch intake. Keto diet appears to be much better in terms of avoiding hunger and sugar craving, at least how the patient described, but drifts towards Mediterranean diet. As a matter of fact, turns out when we're left on our own, we all drift towards more sugar and more refined carb intake. And the issue is not with the Mediterranean diet, but the issue is with keto diet, because if you go up on your fats and then you go up also on your refined carbs, then that's a potential deadly situations from cardiovascular perspective. Now, we don't have prospective randomized studies to look in the safety of keto diet from cardiovascular perspective long term. However, we do have data from a telehealth company called Virta Health that was founded in 2015, and they actually are very serious about publishing their data. This is an example of 1, 2, and 5 years follow-up. This is not a randomized study. These are patients compared with their own baseline, own enrollment in this telehealth nutritional advice about keto diet. And what you notice here on the metabolic profile, actually the LDL cholesterol indeed, as confirmed, goes up by total LDL cholesterol, goes up by about 10%. But if you look at hemoglobin 1C, this is actually a dramatic improvement by about 20%. By the way, this is probably as efficacious or even more efficacious than any drug that's ever been used in diabetes, including insulin. There's then ApoA1, which is a marker for HDL, goes up. Triglycerides go up, down by 33%. And then when we look at the LDL subparticle, particularly small dense LDL and VLDL, they actually go down, including high sensitivity C-reactive protein, and overall improves the cardiovascular risk score for these patients. So the big question is, what about retention rate when a dedicated telehealth company that coaches you every day for the next 5 years? What's the retention rate for that? And they actually have, at 5 years, 20% of patients actually have been cured from diabetes. They reverse diabetes. 1 out of 5. About 33% actually are in remission, with being only on metformin and a pre-diabetes stage. And the retention rate was at 1 year was 83%, 74% at 2 years, and 50%, actually half of them by 5 years. Some of them actually, they stopped doing that because they got better and they decided to do it on their own. So what this shows us that if you were to try to implement any kind of diet, you have to continue with the persistent coaching if you want to maintain that. Humans tend to go back to their own habits, and you can improve that. Now, when it comes to prospective randomized studies to look at a potential of reversing type 2 diabetes with keto diet, unfortunately, we don't have good quality long-term randomized studies. I do know that a lot of them actually are in the works, so hopefully one day and soon we're going to have those. But until then, in summary, really Mediterranean diet, and I like the concept of Mediterranean Plus that Dr. Gardner has emphasized, try to avoid the refined carbs and sugars, is the most studies, and we have the most evidence for this. The keto diet actually looks very promising, appears at least in short times, up to 2 years, to be as safe and as good as Mediterranean diet for those who are interested and willing to do that. Unfortunately, it requires proper coaching from experts, and also we don't really have yet long-term randomized studies about proving safety and efficacy from cardiovascular perspective. So now I'm going to move from prospective randomized studies to less, to epidemiologic studies for which we start to have conflictive evidence. And really, the question is, which diets are helping us? Low-carb diets versus low-fat diet. And I'm going to start first with the Harvard group, who is led by Frank Hu, who published in Journal of American Internal Medicine in 2016, looking at a database, large database from over 30 years, mainly the Nurses' Health Study 1 and 2 and healthcare professional, over 200,000 people followed for 30 years. And they found that trans fats are definitely bad for us from cardiovascular perspective. Saturated fat appears to have an increase by 10% risk of cardiovascular disease, but monounsaturated fat and polyunsaturated fat appears to be protective. So then in contrast to that, we have the McMaster group led by Dr. Salim Yusuf, who was actually a cardiologist who published the PURE study that was designed in 18 different countries in 5 different continents. And what they found is that actually, if you look at total fat intake, particularly if it's more than 25-30%, actually could be protective, as opposed to carb intake over 60% actually is associated with worse cardiovascular risk. So this is in contrast to what the Harvard group has shown. Really, they also found and confirmed that the monounsaturated fat and polyunsaturated fat are actually safe from cardiovascular perspective and may be protective. And this is a Cochrane review of actually the most recent one that was done on the issue of whether if we reduce saturated fat in cardiovascular disease, improves cardiovascular outcomes. And notice there is no evidence actually from prospective randomized studies when you pull them together that helps. What about vegetables and fruit intakes? And this is where everybody seems to agree. The more fruits and vegetables in a dose-dependent manner is protective from cardiovascular perspective. That's the PURE study, but also the Harvard group showed the same. And another interesting finding from the PURE study is actually dairy intake. I'm talking about whole milk and yogurt, not the skim processed version, is actually also protective and inversely related to cardiovascular disease. So last but not least, I'm going to dedicate actually most of the current discussion about really looking at where is the real danger coming, from. And I'm one of those where I think that actually ultra-processed food, and when you combine refined carbs and refined fats together in ultra-processed food, what causes cardiovascular disease. And here is what's wrong with the standard American diet. That's named actually by outside the SAD diet. Usually we used to eat 2,500 calories a day. We're actually up to 3,600 calories a day in average in this country. I'm going to take the bull by the horn and talk about meat first. So you can look actually, when it comes to meats, you can look at grass-fed beef, you can look at corn-fed beef. Indeed, it seemed to make a difference, at least in the macronutrients. But really the big difference is not so much in saturated fat. It goes up just very low. It's omega-9s seem to be going up twice. Omega-3s seem to disappear once you move them from grass-fed to corn-fed. You have 3 times higher risk of actually multi-drug resistant bacteria in the diet. But they also, because they are fed with corn, they are loaded actually with branched-chain amino acids. So instead of, I'm going to talk to you about the real danger. And indeed, overall, red meat consumption has been associated with cardiovascular disease. The relative risk ratio here is 1.17. If you compare with LDL per se, is 1.4, triglycerides 1.8. So it's, I'm going to talk about actually the real dangers of meat that are associated with meat consumption and cardiovascular disease. And I'm going to bring on 3 mechanisms. Number one is actually they come up with a lot of branched-chain amino acids. And why is that important? Because we have evidence that actually branched-chain amino acids, excessive branched-chain amino acids, and those are valine, leucine, and isoleucine. That's from, by the way, protein shakes and protein supplements, or from corn-fed animal feed meat. It's actually causes insulin resistance, fatty liver, and it's associated clear with obesity and with cardiovascular outcomes. And the reason is because it stimulates chronically this mTOR pathway that actually changes the phenotype of our cell towards insulin resistance, inflammation, and storic phenotype. Branched-chain amino acids are essential for our diet. As a matter of fact, that's how we grow our muscles. The key is if you exercise, you have a pulsatile release just for 2 hours, and then you incorporate those amino acid in your muscles. But if you don't exercise and you take your protein supplements, that's actually going to cause fatty liver and metabolic syndrome. So the second mechanism I'd like to show here that we have a major warning is actually the fact that meat from corn-fed animals actually are loaded with carnitine, phosphatidylcholine, and choline, which are converted by our gut microbiome into trimethylamine, which then is further oxidized in the liver to trimethylamine oxide, TMAO. And TMAO has been associated with coronary disease, huge risk factors, peripheral vascular disease, type 2 diabetes, chronic kidney disease progression, fatty liver, and colon cancer. So that's the second one. The third one is actually, there's very little discussed, and I'm going to probably shock you a little bit, is actually, here is 3 different kinds of foods that we eat every day. This is chicken that has been just grilled. You didn't add any oil on it. This is baked potato, and this is fish. If you were to look at, if it's cooked at 300 grams, you have very little fat into this chicken. But if you fry it, suddenly we have 14 grams. So the fat content goes up by 50 to 100-fold. And it's not really the saturated fat. This is actually the fat from the vegetable oil, which is omega-6, and they're oxidized at 300 degrees. The same goes for French fries, and the same goes for fish. So for lack of a better word, we got other fish to fry here. So fish is great for you, but I don't advise to actually fry it. And the reason is these are not just omega-6s, which otherwise are healthy and essential for us. They're actually highly rancid and oxidized. And of course, if you go to eat a burger, this 3 times more, and commercially available French fries from fast food chains is about 6 times more. So suddenly, if I were to do a food diary, am I dealing here with a carb source with these French fries, or it's actually a fat source? Because they seem to have been loaded with both. So I'm going to talk a little bit about here the omega-3s versus omega-6 versus omega-9s. And, there are essential fatty acids. We need omega-3s for our cardiovascular and brain health. We need our omega-6s for arachidonic acid production and cortisol and sex hormones. And we need omega-9s to actually help us burn the saturated fatty acids. But you see what makes them essential is these double bonds. We have 3 of them, minimum linoleic acid. Actually, in EPA, DHA goes up to 6 double bonds. You have 2 in omega-6. You have 1 in omega-9. So what makes them essential also makes them very heat sensitive and very prone to oxidation. So if you were to actually hit these oils and you fry anything with it at 325 degrees Fahrenheit, they actually produce trans fats. They convert and they produce oxidized omega-6s. And if you compare this, appears that extra virgin olive oil here compared with lots of different vegetable oils seem to be a little safer. And the reason is because it's got omega-9s, which only have 1 single double bond. So that's a little safer from that perspective, but they still have 10% of their fats, linoleic acid, which is omega-6, which contributes to the rest of oxidation here. And, this is the olive oil combined with sunflower oil and actually showing it generates trans fats. You can generate that just fine in your dish. We know trans fats have been banned actually from our ultra-processed food in 2003 by FDA. However, the far more toxic aldehydes that are generated actually when you fry some using vegetable oils are actually could be more potentially dangerous. And why am I trying to capture attention about these oxidized omega-6 from vegetable oils? Because if we look at LDL, the LDL that really causes atherosclerosis is the oxidized LDL. And that oxidized LDL requires 2 steps. One is glycation of ApoB100, which is our receptor for LDL. And that makes it actually, once ApoB100 is glycated, it makes it actually less recognizable by the LDL receptor in the liver, which is the main mechanism how statins and PCSK9 inhibitor work, and explains why statins actually have very little impact on this oxidized LDL. The second step is the cholesterol oxidation with esters. by fatty acids. And the main fatty acids found in these cholesterol esters in oxidized LDL is linolenic acid, omega-6, which can only come from diet. So if you oxidize this, it can find easily its way in the oxidized LDL. And if you were to look at how do we generate, we could potentially have the sources of glycation versus oxidation of the LDL. We can actually find that easily from glucose and fructose, in particularly if you heat them up. Here, it's example of a creme brulee, which I very much enjoy if you brown it, but we can, French fries can be actually both sides of the coin once you fry your potatoes. They're also been shown to cause fatty liver. So I'm trying to warn you about oxidized omega-6s and from vegetable oils. The trouble is that actually a recent meta-analysis that was published in 2019 by world experts in clinical epidemiology have shown that actually a plasma level that's high in omega-6 seems to be protective from cardiovascular, disease. So actually they continue to encourage the American Heart Association guidelines to make us, advise us to increase our actually vegetable intakes in the diet. A word of caution here, actually, if you were to look into omega-6 contains in our fat adipose tissue in the last 50 years, actually has gone up from 7% to 21%. So really, it's not like we've been missing the omega-6s in our body. As a matter of fact, it correlates with our linoleic acid content in the body. And what I think happens here is what matters is the oxidized version of linoleic acid, which is actually very difficult to measure in the plasma and matters what our tissues are seeing. So this is, to me, an example of reverse causation. In people who are healthy, have healthier omega-6s. It's not because necessarily a higher level of unoxidized plasma linoleic acid is the problem. And just want to show you, of course, this is an animal model of atherosclerosis, the apolipoprotein E knockout mice, which are unable to, which have high LDL. They're actually the main animal model we've been using for the last 30 years. And if you were to look at their fed on the high-fat diet, their oxidized plasma LDL level goes up about 10 weeks before actually they develop aortic atherosclerosis. By that time, actually, it starts to go down. So what's important, I think, for future is to actually measure the oxidized form of this linoleic acid or any compound that we think could be related to cardiovascular outcomes. And if you actually were to look in the unhealthy populations, this shows you in the patients who population of heart failure, there's clear correlation between the oxidized linoleic acid and plasma level of unoxidized linoleic acid in this diet. And if we were to look in diabetics, and I'm surprised they were able to do this kind of study. Actually, they randomized patients with diabetes or controls, whether it's poor control or not, to fried meat in corn oil. And they measure actually, they wanted to test whether these oxidized omega-6s actually make it into our bloodstream. So they measure actually plasma chylomicron oxidations after they eat this kind of diet. And you can notice that if you're healthy and have a good antioxidant reserve, not much difference there. If you start to be diabetes, even controlled, you start to have some of these oxidized chylomicrons in your bloodstream. But if you have poorly controlled diabetes who have much lower antioxidant defense, is actually a tremendous increase. So yeah, this kind of substance actually compounds make it in our bloodstream. And what's the evidence that oxidized actually omega-6s are present in the human atherosclerosis? And I found this study fascinating because it's the only study published to date that look at actually human fetal aortas. These were from pregnant women who had spontaneous abortion and clear the 4-hydroxynonenal, which is an oxidation product of linoleic acid, was found colocalized with in atherosclerotic lesions in these fetuses with the LDL receptor and with foam macrophages. And what's fascinating is that these women had all hypertriglyceridemia and was worsened during the pregnancy, proving that they probably had insulin resistance. So we can have this, and obviously the fetus doesn't eat, got all the food from the mom. So this just proves the concept that really everything we eat eventually makes it in our body, but whether our body is able to deal with that depends on our antioxidant defense, and also if we have disease like diabetes, whether it's controlled or not. So I am, contrary to our guidelines, I actually don't recommend use of vegetable oils, at least for frying. And because of this prone oxidation of omega-6 fatty acids, probably the best evidence and the safest appears to be the fruit oils, such as extra virgin oil or avocado oil. And the main reason they're loaded with 80% with omega-9s, which seem to be a little safer. For those who are worried, oh my God, I'm going to be deficient in the omega-6 fatty acids. No, we're not, because they still have 10% linoleic acid. We got plenty of sources of linoleic acid in our diet. What about omega-3s? And here's about omega-3s. Actually, I thought it would be a useful lesson to go back to the Lion study. Why? Because they look into, okay, it was successful. It reduced cardiovascular outcome by 73%. But what was really major different in their diet is actually was the omega-6 to omega-3 ratio that dropped from 19, which is pretty much average what we eat, what an average American eats today, to about 4.4. Ideally, we like to have this actually closer to 2 or 1, if it's possible. And other than that, the omega-9s were a little higher, but in terms of meat and fish consumption, wasn't really major difference between two diets. They had a little bit more fruits and vegetables, but only 20%. And they did, in the Mediterranean diet component, they cut the processed meat out, and that might have helped with this ratio. And where is this important, this ratio? Because omega-3s are essential for us. And the backbone for that is actually linoleic acid that can come either from vegetables or from fish. But the conversion rate of linoleic acid to EPA that provides cardiovascular protection, or DHA that seem to be more useful for brain protection, is actually less than 1%. So we really totally depend actually on our DHA and EPA to come actually from diet. And the fact that EPA seem to be a little more specific for cardiovascular protection was shown here by Dr. Preston Mason, who is a biochemist actually at Harvard, who actually look the ability of various antioxidants to prevent lipid hydroperoxide and oxidation formation in response to hyperglycemia. And EPA was actually very potent antioxidant to prevent that. If you look at the controls, the other actually fatty acids, they are similar, monounsaturated, didn't make a difference. And the reason is because the EPA has this ability to insert in the lipid bilayer and prevent the lipid peroxidation chain that happens at the original cholesterol crystalline domain. So it's something more to that. If we were to look at actually different populations that have different plasma omega-3 levels, if you look at Japanese here compared with the rest of the world, they have about 4 times higher plasma level omega-3s. They also happen to have 2 to 3 times less incidence of coronary disease, despite a very high incidence of smoking in Japan. But probably the single most important benefit is actually, these are a couple of studies, one published in JAMA, one published in New England Journal. It turns out that if we measure the omega-3 fatty acid index, so this is like a hemoglobin 1C from red blood cells membrane equivalent for omega-3 levels. And if you have at least 7.3% of your omega-3s in your red blood cells plasma membrane, the risk of sudden cardiac death is actually close to 0. Of course, these are not prospective randomized studies, so you have to take it with a caution data. But there's also, again, if that index is over 8%, it's extremely predictive of very low risk for coronary disease, if we can get there. And if you actually compare this with the high sensitivity C-reactive protein, which right now is considered probably the most sensitive we have, a omega-3 index over 8 is more powerful predictive of not developing coronary disease than a lowest possible level of high sensitivity C-reactive protein. The catch with the omega-3s is that it's hard to get it in our diet. And here the same Dr. Mason actually did a study where he looked at 4 commercially available fish oil supplements. And we analyze actually what they have. And turns out less than 30% of those capsules have actually omega-3s. Actually, about 36% was saturated fat. If you try to actually supplement with 2,000 milligrams equivalent of fish oil, you actually end up getting 20 grams of saturated fat in your diet, which is, by the way, the maximum allowance for a day just from that. Not only that, but these actually are highly oxidized and rancid. Omega-3s and obvious comes with omega-6s too. Here is the degree of oxidation compared to prescription grade omega-3 fatty acids. So when it comes to actually supplementation omega-3s, I encourage my patients to eat their cold marine fish, ideally 2 to 3 times a week, or they can get from, if they're vegetarians, from avocados or nuts. And in summary, for marine fish are good for you, just don't fry it. Capsule of fish are not. So what about the other side? I talked to you about the omega-6 component and oxidation cholesterol. What about the glycation component that can come from our diet? And this is what the reaction, what we call browning. I would like for you to remember that methyl glyoxal is a catabolic product of fructose metabolism. And if you were to, it's actually also an advanced glycation end product. It's a dicarbonyl that's highly reactive with arginine or lysine residues in our proteins. And sure, we know about glucose. We know about fructose causing that 7 times faster than glucose. They can glycate our hemoglobin, but also methyl glyoxal is actually even more important. And it turns out you can get a lot of this methyl glyoxal by actually frying our meats or food. And I'm going to show you some data for that. For now, just know that elevated methyl glyoxal or cumulative methyl glyoxal production in our body has been associated with every single chronic human disease. Whether it's causative or correlative is hard to know, but it's considered now actually to contribute to our aging. And yes, you can find it in our human atherosclerotic plaques. This is unstable human carotid artery plaque that shows staining with methyl glyoxal, colocalized with foam macrophages, and actually evidence of unstable plaque here as noticed by activation of apoptosis cascade. And there is a group in Mount Sinai who actually looked into generation of this methyl glyoxal after you actually heat or fried our food. And this is the beef kind of data. If you look without cooking, raw food has some of this methyl glyoxide. There is also, they also measure carboxymethyl lysine, another H product. But as soon as we start processing this, look, it doesn't matter what oil you're going to use. It gets extremely high, about 10 to 20 fold. Here is as a positive control pizza. Frankfurter, of course, has the highest level. It doesn't matter whether you boil or grill it. And yes, grilling can create a lot of these advanced glycation end products. If you look at chicken, no difference. What makes it the worst for browning and glycation is actually barbecuing, of course, because we add the sugar, the brown sugar on top of it, and the sweet sauce. If you think that we're safer, and I use this here as a positive control pork bacon, which we kind of know it's a problem. But really, turkey burger is not any difference from this perspective. And actually, might as well eat the nuggets from McDonald's. So heating is what the issue is here. Heating actually high and dry. And last but not least, actually the highest age level per gram of food was not found in those, in the meats, was actually found in the ultra processed food, anything that starts with C, crackers, chips, cookies, granola bars. Why? To get that crispy nature of it, you have to heat under low humidity at very high temperature, often 2 or 3 rounds of over 400 degrees. So that is the key take-home message here. And what I like about this, actually, the authors also did a little experiment where they actually pre-marinated the meat with acids like lemon juice or vinegar. And they found that actually if you pre-marinate the meat with vinegar or acid, you actually are able to reduce by 2/3 those H compounds. So it turns out that actually Greeks like to put lemon in and marinate with lemon all their fish and meats before they actually grill them or cook them. So there is also not just a Mediterranean type of diet, but also Mediterranean style cooking that seem to be protective. By the way, there's a similar technique when it comes to stir frying in actually Chinese cuisine. The old traditional way, actually, they first add the vegetables. After the vegetables heat up, that's when they add the oil. We tend to do the other way around, which makes a big difference. So you try to preserve the humidity and lower the temperature you cook and slow. And then you could say, okay, well, these things are in our diet, but the gut can deal with it and you don't have to worry about them getting absorbed. That is actually not true. This is 24 patients. This was published actually in Circulation. 24 patients with type 2 diabetes, a hemoglobin A1C more than 7. They were randomized to this low age versus high age diet. There was about 5-fold difference. It was actually literally the same food, except one was fried, the other one was cooked at low temperature. And they measure what I like the most, and we need lots more of these studies, is to really, they measure both the age part of the LDL, but also the oxidized LDL. If you look at controls and you compare diabetes with control, you have twice more of this age and oxidized LDL. And if the patient had poorly controlled diabetes, it was 4 times more. So yes, if you're healthy, probably your own gut and body can deal with that stress. But if you're not healthy, clear there is an impact, negative impact in eating that kind of diet. And here I showed you what happens when we just try to process a simple product like a potato. This is the baked potato. Then we have the French fries at home, French fries from fast food, and the ultra-processed chips. And what you notice here, of course, everything just escalates in terms of calories and carbs and fats that you have there. But look at the amount that we eat if we were to eat in one session. You scale up from 1 baked potato, 3, 10, and eventually could actually eat equivalent of 15 potatoes in a 400 grams bag of potato chips, which is the equivalent what calories of what you are to eat in a day. And the ironic part, you're still hungry after that. So yes, processing doesn't allow us just to get toxic compounds in our diet, but actually makes us eat lots more than we think. But it also destroys the antioxidant enzyme once you process. Which is vitamin C, carotene, vitamin E, lycopene, anthocyanin, polyphenols. They actually all work together to protect our gut. And pretty much this is summarized here, that ultra processing doesn't just convert healthy fats and healthy carbs into refines one and bad ones, but also makes us eat lots more. And if you were to measure actually the source of saturated fat, less than 30% really come from natural compounds. About 70% actually comes combined with carbs, but are labeled as saturated fat. So imagine that I'm doing an epidemiologic nutritional study and I'm not looking at whether this is refined or not refined. And I'm going to look at this milkshake and I'm going to call it, well, it's fat. I'm going to count it as fat. Turns out it's got 80 grams of sugar. And the other, vice versa is true. French fries will be labeled in an epidemiology study as a source of carbs. Not true. They actually have 57 grams of polyunsaturated oxidized omega-6 fats. So no wonder the clinical epidemiology studies are actually very confusing about the outcomes. What's the evidence that actually frying is bad for cardiovascular disease? We have now about at least 3 meta-analyses that look into that. This is one that was published in 2021, showing that actually there is an increased 28% increased risk of major cardiovascular disease. And the highest impact appears to be actually on incidence of heart failure. Fried food causes heart failure. And this was actually confirmed in the InterHeart study. And this was actually recently confirmed into a dose-dependent, depending how many of those servings a week you had, with the risk of heart failure would go up by almost 2-fold. And this is the physician health study. In summary, it is really not the macronutrients, which is fats or carbs, that seem to cause the damage. We actually have, this is where evidence is conflicting, is actually when we process them together and we eat them as such, that converts healthy fats and carbs into a healthy combination, makes us eat lots more and increase our energy intake, and inactivates the natural antioxidants. So I'm going to switch back gears to the epidemiologic studies, because now we actually have some evidence of epidemiologic studies and connection between ultra-processed food and and cardiovascular disease. So here's where I look into actually where McMaster studies agree with each other and where they disagree compared to Harvard studies. They agree that trans fats are bad for you, fruits and vegetables are good for you, unsaturated fat are good for you. They disagree in saturated fat, dairy, and carbohydrates, which is actually, if you were to split them into natural processed versus unprocessed, you can see why is the confusion about if you collect your data only from just dairies and diaries, I'm sorry. And basically, I prefer to split this into healthy carbs and fats versus unhealthy processed carbs and fat. And if we can have a way of how to separate those, maybe we can design more reliable epidemiologic studies. And really the help and a game changer came from Dr. Carlos Monteiro, who is professor of nutrition epidemiology at University of Sao Paulo in Brazil, who in 2009 came out with a NOVA classification of ultra-processing food. He noticed in Brazil that actually with time, the more people start to eat ultra-processed food, they stop cooking. So he defined the NOVA class 1 as food that we actually just take the natural compounds and we cook them at home. Processed NOVA 2 will be salt and sugar. 3, you combine them and you cook them at home, or you just buy them at the industrial level, but there is no additives added. 4 is the standard package label food that comes already: ice cream, sugary drinks, baby feed formulas. They're all ultra processed. This is an example of actually a healthy, unprocessed Ezekiel bread that's industrial available. It's just the ingredients you would expect to make the bread. And if you were to look into this is an ultra processed version of bread that has about 20 different compounds that we don't know what they are. And here's what we define actual ultra processed food. And this is how I tell my patients: is ultra processed food contains additives. Came up with this acronym called FEPS: flavor enhancers, emulsifiers, preservatives, sweeteners, and that's how I identify it. Adds sugar and fructose, and you can forget, and you can also ultra process at home. Frying causes the same thing. So the NOVA classification system actually now gave us a tool that actually can try to quantify the ultra processed food in our diet. And of course, in the last 50 years, we have increased. We eat over 55% now in our diet from ultra processed food. And of course, we have that took over the cooking at home kind of diet. And if you were to look at what kind of foods tend to be ultra processed, the least processed are the vegetable and fruits. And no wonder everybody agrees on that concept. We are currently at about 62% of Americans, actually, I'm sorry, Americans eat 62% of their diet from ultra processed food. The biggest actually risk is teenagers, 70%. And 90% of our added sugar actually comes from ultra processed food. So Dr. Kevin Hall from NIH said, what's this thing about ultra processed food? He actually did a controlled study where I actually admitted healthy people for 4 weeks in the hospital and gave them the food, and then look into pretty much they give them the same percent of macronutrients, lipid, proteins and carbs. And some of them were randomized to ultra processed version, 80%, some of them to minimal processed diet. And within 2 weeks, notice that actually the ones who are ultra processed, they gained 2 pounds, while the ones who were unprocessed food, they lost 2 pounds, which means there was a 4 pounds actually difference from one to another, just 2 weeks. And they had similar kind of exercise, 60 minutes a bike a day. What really happened when they look at their hormone levels, actually, they had the ultra processed food version, they gained weight, had higher insulin, higher leptin, higher ghrelin. So it shows you that also the metabolic profile went the wrong way there. And this was correlated with the excessive, in excess of about 500 calories a day food consumption in these people. So, and now we have evidence of ultra processed food actually correlated with obesity. We have evidence of ultra processed food from the 5 different countries associated with worse cardiovascular mortality, all-cause mortality, obesity, metabolic syndrome, depression, and dementia. Also, new onset type 2 diabetes is predicted by that. This is the Harvard group. It's recently published. I'm going to show you one more study. And when it comes to epidemiologic studies, the best way to try to improve the validity of these studies, try to find quantify the risk factors and exposure to the disease. And this is an Italian study that was actually published this year, where they look in type 2 diabetic patients in a county, Molise in Italy, and they follow over 11 years to see whether ultra-processed food consumption predicts mortality. And at baseline, they only had 3 to 4% actually using ultra-processed food from their diet. And you wish you were Italian, because we're at 60% here. But those who had the highest quartile, 14% consumption, there was 2.6 fold increase in cardiovascular mortality, which is one of the highest number we've seen so far. And they actually predicted that for each 5% increase in ultra-processed food in the diet, there's 1.47 risk of 11 years of dying of cardiovascular mortality if you're type 2 diabetic. And this is just hypothetical. If you were to convert that to the 60% in the US, that would be equivalent of 15-fold if they were true. So it's a serious issue here. And more recently, Dr. Frank Hu actually, and their group at Harvard actually look and quantify the same way low-carb diet, looking at different types in our prospective 30 years follow-up, 203,000 people cohort, which is a mix of nurses health study 1, 2, and healthcare professionals. And what they found is that when you look at the type of food, the source of the carb, and if you were to eat an unhealthy and animal predominant low carb diet, as defined as eating sugar, refined carbs, and processed meats, it actually led to worse outcome. If you cut those out, actually had better outcome. So even if it's low carb diet, if you actually eat the refined version, actually can make it worse. And the same goes for vegetarians and vegans. And then subsequently showed this was not only important to predict new onset diabetes, but also for cardiovascular mortality, whether you had diabetes or you didn't have diabetes. And basically what this allowed us is to separate healthy low carb from healthy low carb that you add actually refined carbs and sugars, and those are bad compared to the others. And they further actually look in another study that was just published recently, different patterns of eating, whether it's Mediterranean diet, whether it's plant-based diet, DASH, American Cancer Diet, and some anti-inflammatory diet. And it turns out by the pattern, again, this is not a prospective randomized study, just try to look into the preference of kind of food types people eat and whether it predicts outcome retrospectively. And all but the American Cancer Society diet actually were useful, but the most pronounced were this anti-inflammatory diet food pattern and the anti-insulin resistant diet. And they have prior published actually how they got to those type of dietary patterns. And if you were to look at what kind of food compounds do this, is literally ultra-processed food. They stopped short of saying the name ultra-processed food, but that's what they found, as opposed to whole foods, which were protected. And here, I just want to make a point that low-fat dairy products, the skim milk, the low-fat milk, actually was into pro-diabetic kind of diet as opposed to full-fat milk. And the reason is, when you take the fat out, you add back the sugar, 12 grams of sugar per serving. And they got very creative with that. Now they say no sugar added, but then they add sweeteners. And then the same for the inflammatory diet. I just want to make a point of the wine seemed to be actually extremely powerful next to coffee and actually protecting us. But here is the bias that we have. They actually look into different amounts of servings of wine a day. So you're healthy if you just drink 1 glass of wine. Once you start to have more than that, it goes away. So this is an example, actually, reverse causation in an epidemiologic study. People who are healthy are managed to drink just 1 glass of wine a day. It's not the other way around. But I'm glad they did that. So to clarify, doesn't mean a glass of wine per se may not cause it. We just don't know. All right. And really, Dr. Kevin Holt says ultra-processed food is bad for you because actually it makes us eat more. But also, we found out now what food industry has known for over 50 years, that they have the bliss point when they create any kind of cookies or chip. Basically, it's the right combination of sugar, salt, fat, texture, smell in food is what we call the umami test, that actually triggers our brain reward system to disrupt our body's natural, hey, we are full mechanism, we keep eating. And this is by adding these FEPS additives kind of products with sugar together. And we eat more because actually refined carbs makes us eat more. That's another reason why we get hungry. You know, an average American eats about 8 times a day. It's 3 meals and 5 snacks. Do we really need to eat that much? But if you ask somebody, they'll say, well, I'm hungry. And the reason why we're hungry is because refined carbs makes our insulin spike, causes secondary hypoglycemia within 2 to 3 hours, triggers our hunger hormones, and actually makes us eat immediately, right back up. So there is no diet that's going to work unless you cut the refined, carbs, and unless you stop being hungry. And that's the take-home message here. Any diet really will work. Sweeteners, artificial sweeteners, are not any different, by the way. Our behavioral neuroscientists have known that it encourages your sugar craving and craving. Sweeteners also appears to cause metabolic syndrome, at least in mice and some in humans, because it changes our gut microbiome. And I was going to show you that really by just juicing or smoothing our oranges, you increase our fructose bioavailability by 200 or 300%. By the way, apples have 70% fructose, so actually they are genetic and engineering, they're sweeter. So we make sure we eat more of those. So, but if you eat berries, and this is why I recommend to all my diabetic patients, lots of fiber, very little fructose, you can eat unlimited amount. I promise you won't eat too much because the fiber will make us feel full. And in conclusion, this is how ultra-processed food, by being exposed to these 4 different components, it causes metabolic syndrome, but also obesity, stimulates our food intake. And depending on your genetic background, you may become you're able to accumulate fat, you get more obese and have a lot of subcutaneous fat. But if you are thin outside, fat inside, you may get fat in the liver. And we are not what we eat, but we are what has been done to what we eat. I know Pooja says that I'm way over my time, so I'm going to skip to the slide. You're doing a fabulous job, by the way. Let me see, how do I go further? I did want to make a point that really is not the macronutrients that matter, but actually the food patterns and how we cook that makes the difference. Please close your eyes. Just eating first the salad before you actually eat your entree seem to make a difference in terms of insulin spike. So actually, I tell my patients, eat first your salad. I recommend actually, but don't put one little lettuce, just a pound of salads and vegetables. Start with that on your main meal before you actually eat your food. Why? Because fiber protects our gut and our liver. It's food for prebiotics and probiotics. And it actually, both the insoluble fiber protects our mucus, it feeds the bacteria, the healthy bacteria, who have actually a lot of beneficial effects. And it turns out it's essential for the immune system in the gut. By the way, 90% of our immune system is concentrated in the gut because our gut is a sewer. So it turns out that if you don't have enough fiber and you have a lot of sugar and fat in your diet, you actually change your T cell population to suppress the Th17s and create a pro-inflammatory gut and metabolic syndrome phenotype. We know that increasing our fruit and vegetable intake from 2 to 5 servings makes a big difference. Good food is medicine, bad food needs medicine. And any diet really works, provided that it's not processed. But we also need, any diet will work if we stop being hungry. Otherwise, you can't really sustain long-term. So what makes us not be hungry? Actually, any food that's natural, that either high fat, high protein, or high fiber. And the reason why we have all these different diets is not because they don't work. They do work. They just may work different for different people. So actually, while the good news is the Mediterranean diet finally has been now encouraged and it's accepted by American Heart Association. But any patient, if they want any kind of diet, I'm just careful, make sure I follow certain metabolic markers, but I encourage them to do what they like to do as long as it's supervised. And because as long as it's from whole food, I know they're not going to be hungry and they're going to be able actually to increase their nutrients and reduce the energy they eat as opposed to what happens from ultra-processed food. And the main advice I give, no matter what food you eat, avoid refined fats and refined grains and carbs. I think I'm going to stop here. But for those who are interested, what I tell my patients is what I show them. So I'll be happy to take any questions.
Okay, great. Thank you, Dr. Surescu, for that wonderful presentation. You're just 5 minutes over, so it's okay.
Thank you.
Go ahead, Dr. Comment?
Dan, first, I just want to congratulate you on taking this topic on, the amount of work that you put into it and the interest that you put into it. And this stuff, to me, really matters. And I think we need to have more types of presentations like this. The next part of this, other than educating us, would be how do we market this to our patients? And in part, we do a very poor job with that. We debate different things, but rather than just saying this is bad for you, don't do that, that sort of thing. For the patients who are taking GLP-1 agonists, I ask them, how are you doing? And they routinely say, I'm less hungry. And they see that as a big benefit. In these various diets, when they look at, do they measure satiety indices or whatever? And how do we focus on foods that would decrease hunger? You know, often when I saw you put up decrease hunger, you know, worldwide, it's like, oh, people are hungry. Let's get rid of that. But how do we keep our people from overeating by being hungry?
So actually, I didn't mention, but all those trials, Mediterranean diet versus keto diet, actually, there was food was at ad libitum. They were allowed to eat as much as they want. There wasn't any calorie restriction. They still lost weight and improved their metabolic profile. And the reason is the key was to eat, unrefined either carbs or fats. In other words, whole foods. If we eat whole foods, fiber, if we increase, I tell my patients, any main meal, I want you to have a pound of vegetable salads, and you start eating that. If you eat fiber, you're not hungry anymore. It will last you for a long time because it allows us to slowly release those carbs over time. High fat, believe it or not, actually all the patients who are on keto diet, they say they stop being hungry. Again, as long as it comes from whole foods. And then last but not least, there are also paleo and people who believe in just eating meat. They're also not hungry. And of course, we don't know the cardiovascular risk profile long-term for those because clear they have increased LDL cholesterol. So those are, as long as you eat from that, appears to make a difference. In terms of how we advertise this to the patients, part 3 of this is actually for the patients. We have a session in 2 weeks in Glenn Auditorium for the patients, going to be recorded. So the first part was about why, the second was what, the third will be how. And I literally don't show any data. I just show them pictures of foods, what's good, what's bad, and how to do it. And then, the GLP-1 agonist, indeed, that's what it does. It stops you from being hungry. As a matter of fact, works on that desire, pleasure, reward center. The catch with the GLP-1 agonist is that you don't lose just fat, you also lose muscle. You actually get sarcopenia. So these patients, so we have to be extremely cautious because while they may be better for the next 3, 4, 5 years because they lost some weight and maybe their metabolic profile improved, when they reach 65, 70, they have apparently the muscle waste is actually permanent, and actually they have increased risk of hip fractures. By the way, there are also issues with horrible gastroparesis and aspirations and pancreatitis. There's actually data that just came out this week in JAMA. So we have to be cautious long-term side effects. But it turns out if you eat real food, I encourage the patient to really just commit. You need constant coaches. I tell them you're not going to be comfortable. Somebody has to cook at home, ideally, and you got to clean up your home from ultra-processed food around. Otherwise, you're not going to resist the temptation.
Okay. Thank you so much. I will see everyone next week. And don't forget to get your CME text, that code that Zaina sent out. Thanks again, Dr. Surescu. That was fantastic.
All right. Thank you.
The preceding program is copyrighted by Emory University.